Hello everyone, welcome to Med Lectures Express. I'm Nena Oteloka. My background is in hospital medicine, and today I will be talking about pulmonary embolism because it is a commonly seen condition in the emergency room, and sometimes it may be misdiagnosed. So prompt recognition of PE is very crucial because of the high mortality and morbidity associated with it, which may be prevented with early treatment. So let's dive right into it. Let's take a look at this case presentation of a 32-year-old female who presents with shortness of breath and lightheadedness. Just looking at the screen, a few things hit my eyeballs. We have tachycardia, tachypnea, hypoxia, and Wells criteria of 2. I don't know if you're thinking what I'm thinking, but let's keep going. And what other questions would you ask? Of course, for the fact that this is a very young lady, I would definitely like to know what she takes for her birth control. And her family history is not mentioned, so it's important to know if she has any blood clotting disorders. And the next question is what imaging or labs would be most appropriate. Most appropriate is the emphasis. Here is actually asking you what imaging or labs would help you to diagnose this patient. So in this case, CTA of the chest and D-dimer would hit very high on my priority list. So the patient's D-dimer and chest CTA returned positive, and she's officially diagnosed with pulmonary embolism. So what is a pulmonary embolus? It's an obstruction of the pulmonary artery or one of its branches by a tumor, thrombus, air, amniotic fluid, foreign body, or fat. Pulmonary embolism is the third most common cause of cardiovascular death after myocardial infarction and cardiovascular accidents. And many PEs are likely undiagnosed, misdiagnosed, as frequent as in about 1 in 3 cases. In PE and DVT are similar in manifestation as well as pathogenesis, and they carry equal risk factors. Looking at the pathogenesis of PE, we will see various conditions that can lead to the generation of venous thromboembolism. And Virtuous Triad provides a module for understanding many of the risk factors. The 3 basic elements of Virtuous Triad are hypercoagulability, vessel wall injury, and venous stasis. As for hypercoagulable states, these include acquired and inherited in the form of polycythemia, thrombophilia, cancer, sepsis, estrogen, or hormone replacement therapy. And causing injury to endothelial wall can result from orthopedic surgery, previous DVTs, trauma, MI, CVA, or any indwelling devices. For venous stasis, anything that makes the blood stagnant, as in bed rest, stroke, obesity, varicose veins, immobilization, AFib, and heart failure. Now, most clinically significant PEs often originate in the lower extremities or pelvic veins. About 50% of these events are asymptomatic, and more than 50% of patients with proximal vein DVT also have PE at presentation. Pulmonary embolism occurs when deep vein thrombi detach and embolize to the pulmonary circulation. In the lungs, the lower lobes are more frequently affected than the upper, with bilateral lung involvement being common. Pulmonary vascular occlusion occurs and impairs gas exchange and circulation. Larger emboli wedge in the main pulmonary artery, while smaller emboli occlude the peripheral arteries. Obstruction of the pulmonary arteries creates dead space ventilation as alveolar ventilation exceeds pulmonary capillary blood flow. This contributes to ventilation perfusion mismatch, with vascular occlusion of the arteries increasing pulmonary vascular resistance. Now, peripheral PE can lead to pulmonary infarction manifested by intra-alveolar hemorrhage. Pulmonary infarction occurs in about 10% of patients with no underlying cardiovascular disease. Patients may experience pleuritic pain as inflammation increases. Hemoptysis may be present, but not always the case. Now, as for the cardiac implications, as the pulmonary artery systolic blood pressure increases, right ventricular afterload increases, leading to right ventricular failure. As the right ventricular failure progresses, impairment in the left ventricular filling may develop. Hypotension, decreased cardiac output, and rapid progression to myocardial infarction or ischemia may occur secondary to inadequate coronary artery filling, with potential for syncope or sudden death. There may also be large pulmonary embolus burden with mechanical obstruction, RV strain, increased pulmonary vascular resistance, and hypoxia-induced vasoconstriction. Of course, the consequences may include a AFib and what we already mentioned there, cardiac arrest. Now, Ochsner syndrome is a rare presentation which is caused by a dilated pulmonary artery, and this can present as hoarseness. And so this is something that we need to watch out for. In PE, is a common cause of cardiac arrest or circulatory collapse in young patients, younger than 65 years of age. And female patients seem to have the greatest risk due to the use of contraceptives and hormone replacement therapy. The risk factors for PE may be acquired or genetic. The genetic component include and not limited to thrombophilia, which is an autoimmune clotting disorder in the form of factor V Leiden, and prothrombin gene mutation. For acquired risk factor, we're talking about provoking and non-provoking factors. And the provoking factors include recent surgery, trauma, immobilization, use of hormone therapy, and active malignancy. For non-provoking, we have obesity and heavy cigarette smoking. Now, prompt recognition of pulmonary embolism is very, very crucial. And most commonly reported signs are tachypnea, tachycardia, and dyspnea. Of course, other signs may be cough, diaphoresis, chest pain, anxiety, You may see low oxygen saturations, dizziness, lightheadedness, syncope, and we must not forget to check our patients for signs of DVT, which may include pain, swelling, and redness in the lower extremities. And check out the neck veins to make sure there are no indications of RV strain, which can be seen in increased JVD, right-sided heart sound, parasternal lift, and cyanosis. Now, as far as imaging studies go, chest X-rays are predominantly normal, but you may see some classic signs of PE on the chest X-ray, and these include Hunting hump, Pala sign, and Wester mark sign. And I'll give you a few seconds to go through the slide. Yes, CT chest angio is gold standard in patients with Wells score greater than 6. And of course, the Wells PE score is used to evaluate a patient with a suspected PE to establish the probability that this is likely or unlikely. So we have a scale system that we use. So it's important that you're very familiar with it. Now, for Wells score 2 to 6 and D-dimer greater than 500, we use a chest CT angio. And it's also considered in patients with Wells score 2 to 6, although D-dimer is less than 500, if proximal DVT is present. In conclusion, all patients should receive a minimum of 3 months of anticoagulation to ensure PE resolution. Longer-term anticoagulation is determined by the presence or absence of provoked or unprovoked risk factors, risk of bleeding, and choice of anticoagulant. Now, the IVC filter placement is reserved when therapeutic anticoagulation is contraindicated. Now, to minimize the risk of warfarin-induced skin necrosis in a patient being transitioned to warfarin, heparin and low molecular weight heparin should overlap with a minimum of 2 consecutive days of therapeutic INR. We also need to pay attention to our patients with antiphospholipid antibody syndrome these patients are not candidates for anticoagulation with factor XA inhibitors, which are Xarelto, Pradaxa, Eliquis, and Lisiana.